So my talk, my presentation will be on polypharmacy. So what are the challenges in managing type 2 diabetes in elderly? The polypharmacy, that is leads to economic burden, and we should think about the drug interactions. And when it comes to geriatric syndrome, as Dr. Sunil Gupta sir has presented about cognitive impairment, then we have to address sarcopenia, frailty, urinary incontinence, falls and malnutrition. So we should look for the complications of diabetes, then age-related changes, like mainly which reduce the efficacy of glucose lowering agents and the highest risk of adverse event, especially hypoglycemia. So this is very important that we should have a comprehensive geriatric assessment for every patient. Sandeep, just have a note of this. CGA is very important, and neurocognitive function in older adults with diabetes. So when it comes to insulin management, you can see this is an algorithm just for our reference. We can give our consensus accordingly how the patient should be on basal insulin, preferably in the morning time, not in the night time, to avoid hypoglycemia. And if the patient in prandial insulin, how the dosage has to be adjusted. This is a simple algorithm which helps us to say the usage of insulin in our patients. And most of the patient is most of the things we should address is the hypoglycemia. When you're talking about the hypoglycemia risk, each consultation should have the evaluation of hypoglycemia. We can ask all these questions like factors contributing to hypoglycemia, practical consideration, and what are the technological management. So we should have a treatment goal for this. Like it should not be like keeping 7 to 7.5 to every patient, as we keep in a younger patient, elderly patient, depending upon the comorbidities. When we are starting the treatment, we can be flexible. If a person of 85 years old, elderly people, we should not be very stringent. We can be very relaxed way and give him the liberty of the options of treatment. So always the recommendations for pharmacological therapy, if you take, the first thing to consider is the hypoglycemic risk. Prefer the medications with low hypoglycemia risk, particularly for high risk individual. In the middle, you can see the most important thing is avoid over treatment. So always try to de-intensify hypoglycemia causing medication, example insulin, sulfonylurea, whenever it is appropriate. On the right hand side, you can see the simplification of treatment plans, that is, reduce the complexity of regimen to lower polypharmacy treatment risk and treatment burdens. So cardiorenal agents, yes, we always talk in younger patient about these things, but to certain extent, elderly patient also we should address this issue. Include medications that mitigate cardiovascular and renal risk in individuals with atherosclerotic cardiovascular disease or chronic kidney disease, regardless of glycemic levels. In the middle, you can see the first line therapy, metformin, safe for most, monitor renal function and side effects. Glitazones used with caution in older adults, especially those at risk for heart failure and fracture. Sulfonylureas used cautiously, favor short-acting options due to hypoglycemia. Incretin-based therapy, DPP-4 inhibitors and GLP-1 agonist. SGLT2 inhibitors, effective for cardiovascular and renal protection. Always assess the risk for UTI. Support assessment, evaluate social support and caregiver assistance to tailor effective diabetes management. Special consideration for adults with type 1 diabetes. We know it's a growing population. Need for essential insulin therapy is always there. Look for the insulin delivery types, how the patient is taking, and what are the challenges for the family and the caregivers, long-term care setting and the education. Always talk about the education. Make sure the patient and their caregivers are given appropriate education. So management of diabetes in frail older adults, always look for the clinical presentation, healthcare costs, and treatment should be individualized. Always address the issue of polypharmacy, control targets like depending upon the frailty, whether it is non-frail, moderate frailty or severe frailty. And most important, we always think both has to be addressed. Most important is hypoglycemia, but we should not neglect hyperglycemia as well. We should not take like 400 is okay for the patient. 200 is okay, 400 is not okay. So that also has to be addressed. So supportive care for frail older adults with diabetes. See, this looks comprehensive, which includes all the things involved about always talk about the life expectancy, then family care, the support system what the patient has got. Dr. Makkars told about the telemedicine as well. Telling is very easy, but we should not neglect that whether the listening patient is understanding what you are telling. So we think that the patient is understanding, but he may not be understanding what you are telling, and that may lead to disaster as well. So health status trumps chronological age. So if the three things: functionally independent, functionally dependent, complex, end of life. Three things you can divide, and according to the three things you can adjust the adjust the lifestyle modification as well as the medications. So medication selection is very important, minimizing the hypoglycemic risk. First line metformin. If the cardiorenal protection, like you can look for SGLT2 inhibitors and GLP-1 RA. Medication to use with caution, once again re-emphasizing on sulfonylureas, and always look for de-prescription. The vicious cycle is managing geriatric syndrome, focus on hypoprevention, address cognitive decline, combat frailty and malnutrition, and optimize non-glycemic factors. Interventions for cognitive decline in diabetes. This is one important slide, Dr. Sandeep, you can see. When you are addressing the pharmacological intervention, there are certain anti-diabetic drugs like GLP-1 RAs, which shows promise in managing hyperglycemia and cognitive dysfunction. DPP-4 inhibitors reduces dementia risk, especially with metformin. SGLT2 inhibitors lessen the cognitive dysfunction. So this is very important. We are putting the medication for diabetes control as well as the other factors also. So emerging therapeutic strategies like dual and triple incretin agonist, longer acting GLP-1 RAs, then cognitive training, and there are many ongoing research about the liraglutide and lixisenatide for memory impairment reversal. Antioxidant and anti-inflammatory agents like curcumin, vitamin E show cognitive impairment in animal models. So lifestyle modification has to be addressed. One important thing when we are writing the conception we should not forget is the end of life care management as well, which is very important to address. Like we should initiate the conversation, and we should give the palliative care objective as well. So then we should have a tailored diabetes management for that particular set of patient. Monitoring of adjustment of the medication, including the family members in the treatment protocol, is very important. So this can be a framework for individualizing treatment goals in older adults with diabetes. So we can have a discussion at the end. Thank you for your patience hearing. Thank you.